Good evening. Tonight we're going to talk about the respiratory system. Respiration has two meanings. The first meaning comes from biology class, and that is the cellular utilization of oxygen for making ATP. So glucose goes in from your food to the mitochondria. Oxygen is added to it. As a result, you're going to get some water, you're going to get ATP, which is the energy packet, and you're going to get CO2 as a waste product. That CO2 is put back into the system, and then it goes to the lungs and it's breathed out. The oxygen stays in the cells so that the cells can do the work that they need to do, and they get that energy to be able to do that. Two phases of pulmonary respiration, which is the other type of respiration that is involved with gas exchange, is inhalation and exhalation. Sometimes you'll hear it as, So inhalation and exhalation are dependent upon the physics concept of decreased pressure. Increased pressure gives us decreased volume, and increased volume gives us decreased pressure. During inspiration, the air that comes into your mouth because the pressure inside the lungs is lower than the pressure outside. During expiration, once you've built up that volume by bringing in air, it increases the pressure inside the lungs, and compared to the outside of the lungs where there's less atmospheric pressure, it's going to force that air to go out. This is an involuntary process. The rhythmicity of it is controlled by your brainstem. It's not something that you're conscious of. In fact, in lab, we found out that when you are conscious of it, it makes it a little bit difficult to control. The respiratory system is connected to the cardiovascular system intimately because once you bring that oxygen in, it has to have a pathway to the cells. Once the cells make the CO2, it has to have a pathway to get back to the lungs to get out of the body. This slide is important for the test because there are a couple of questions from it. We're talking about the 5 steps of respiration. 2 of those steps are bulk flow steps, and 2 of those steps are diffusion steps. So bulk flow, known as ventilation, is where you bring air, which has oxygen, nitrogen, nitrous oxide, carbon dioxide, all of the types of chemicals that are considered to be bad for us. All of that is in atmospheric air. So during ventilation, the first step in the process of respiration, we're bringing in all of that air. However, the only 2 things that we need to exchange with the respiratory system are the oxygen and the CO2. CO2 is relatively a low percentage of atmospheric air. Oxygen is a relatively low percentage of the air. But in any case, the exchange of those 2 things is what we want to focus on for respiration. So bulk flow of air is ventilation, and once it gets into the alveoli, which is a sac inside of your lung, only the oxygen and the CO2 are exchanged with the cardiovascular system, and they are exchanged using diffusion. Oxygen diffuses into the blood, CO2 from the cells diffuses out of the blood and back out to the atmosphere. Then we have another bulk flow process where we're taking oxygen out to the cells, along with all the other things that are in the blood, because oxygen is not the only thing in the blood, as we learned in the hematocrit lab. There are other things. There are red blood cells, there are platelets, there is water, There is iron on the hemoglobin of the red blood cells. There's white blood cells. So there's lots of stuff in here. So this is another bulk flow process. Once we get down here to the cells, where the cells want the oxygen and they want to give off the CO2 waste product from internal respiration, we've got another situation where we're talking about diffusion. So oxygen is going to go into the cells from a high to low concentration. Carbon dioxide is going to go out of the cells from a high to a low concentration. That CO2 is going to go back through the heart to the lungs, into the alveoli, and it's going to be exhaled out into the atmosphere. That process continues so that the cells can utilize the oxygen to produce ATP and produce CO2 as a waste product. The respiratory system has additional functions besides ventilation and the process of gas exchange, and that is that it regulates the pH of the blood. It helps to form sounds for speaking. It has an immunity function, and that is it's going to defend against inhaled microbes. That's done by the upper respiratory system primarily, where it traps things in the air, gets rid of them, breaks them down before they ever get deep into your lungs. It influences arterial concentrations of hormones, for example, and it traps and dissolves blood clots arising from systemic veins in the legs. So we all have blood clots in our legs at different points, and that has something to do with the fact that the veins have to work against gravity to be able to get blood back to the heart and then to the lungs to get rid of that CO2. Having a blood clot show up in your lungs is a very, very negative thing because there's a limited amount of space inside of those alveoli that we talked about. And so you want to be able to break those up before they cause an alveoli to explode and not be able to do its gas exchange job. So this is a review of anatomy, expecting that you understand it from 102 and 101. I can't remember which class covers respiratory, but the upper airways are referred to as the upper respiratory area. It includes everything having to do with the nose, the mouth, and the throat. And so within these areas, there are many, many ways that things can be trapped, because we talked about that immunity function, that things can be trapped before they get into the lower respiratory system and can cause issues such as inflammation, swelling, infection, and destruction of the alveoli. So starting with the nasal cavity, nose hairs trap things and put it into mucus. The mucus has macrophages that break down those substances. If anything gets past the nose, the pharynx has cilia, which are these little extensions from the epithelia that will also trap particles, move them into mucal cells, and break them down with macrophages. The larynx is involved with speech production, and then when that air gets down excuse me, to the trachea, it's moving into the deep parts of the lung for gas exchange. Upper respiratory, lower respiratory. In the lower respiratory area, there's two zones, the conducting zone and the respiratory zone. They are exactly what the words describe. The trachea, the bronchi, and the bronchioles are all areas of a cartilaginous structure that you probably saw when you dissected the pig. It's white, it has rings around it, and it's very stiff. It has to remain open for the airflow, so that's why it's made of the cartilage. So it's the conducting zone, and what it is conducting is clean, warm air. When it gets down to the respiratory bronchioles that are embedded in the lungs, and the end of the line, which is the alveolar ducts and sacs, that's where we start to see gas exchange. These are very, very small parts. The alveoli, there are millions of alveoli in your lungs that allow for that CO2, O2 gas exchange. The conducting zone in general, the most important thing to know about that is it's a low resistance pathway for airflow. It is very smooth. It is supported by smooth muscle on the outside of the bronchial tube that can help to force the air to move into the lower airways. At the top of the conducting zone, you still have some cells that are capable of trapping things in the air, foreign matter in the air that do not belong there. And we'll talk about that in detail in a second when we talk about the mucus escalator. Part of the conducting zone function is to warm and moisten the air and to participate in sound production in terms of the larynx. The mucus escalator that we talked about, so if we were to take a cut out of the trachea before we get to the bronchial branch where we go to the left and right lung, is made up of cells. So if we're looking at this picture, this is one side of the trachea. Imagine that the other side looks exactly the same with the cilia, these green things facing towards the inside. As particulate matter passes through this, it gets trapped in the cilia, pulled into the mucus cells. The cells surround it with mucus that contains macrophages that are capable of breaking it down so that it doesn't end up in the lungs. Over the course of about 10 to 18 years, tobacco smokers tend to have a reduction in the cilia that lines the pharynx. And because of that, there's no way to trap the particles and move them into the mucus area. So they continue moving down towards the lower respiratory area and get into the lungs. Once they're in the lungs, they plug up the alveoli, and the person is going to be constantly trying to move those particulate matters back up and out the body, and that's where you get the smoker's cough. So as I go through the parts of the lungs, I'm going to label them. So the first part that we're going to look at in the lower respiratory area is the alveoli. The alveoli has arterial intervention, both venules and arterials, because that's where gas exchange occurs. And you want to be able to move oxygen into the alveoli and then onto the bloodstream. And you want to move CO2 from the alveoli into the bloodstream so that you can, or out of the bloodstream so that you can breathe it out of the body. So if we were to take one of those alveoli and blow it up, this is what it would look like. We have the vascular system that surrounds the sac. The sac has a lumen, that's the yellow part of this, and the orange part of it represents the cellular lining. It is one cell thick, and it has two different types of cells. This slide is also a slide that you need to concentrate on for the test. There are test questions associated with it. So you have two different cell types making up this orange layer that surrounds the central lumen space, if you don't remember what lumen means. And that's type 1 alveolar cells that help with the structure of it, and then type 2 alveolar cells that produce surfactant. Why do we need surfactant and what is it? Surfactant is a substance that is it's alkaline, it's almost like a detergent, and it provides a lining on the inside of the alveoli to keep the alveoli rigid so that it doesn't collapse when there is no air in it. There's never really a time when an alveoli does not have any air in it because there is something that's called alveolar dead space, and that is space that holds leftover air that is not involved in O2, CO2 production or gas exchange. So the surfactant is designed, it's a liquid that's designed to seal the inside of that lumen so that it will keep it, the cohesion of those molecules will keep it stiff and open so that it can receive air and exhale air. The second part of the lung that we're going to look at is the outside covering, and that's called the pleura, and it exists around the outside. I think of it as kind of like, imagine that the lungs are surrounded in plastic, and that the plastic has a surface that is facing away from the lung and a surface that is facing towards the lung. In between that, there is space. So in that space is fluid. So we have the visceral pleura is facing the heart. The parietal pleura is facing the chest wall, and the space in between those is filled with intrapleural liquid. A lot of times, intrapleural liquid, if you've ever heard of someone having pleurisy, or if you've had pleurisy, it is when you get a viral or a bacterial infection or some sort of inflammation inside this intrapleural fluid that causes swelling, which is going to cause friction either between the chest wall when you inhale and exhale, or primarily when you inhale, or between the lung and the parietal pleura itself. But when this gets bigger, you can imagine that it causes more pressure towards the outside, towards the chest wall, and that can cause that difficult feeling of trying to get a breath and not being able to get it. So we're going to talk a lot about pressure, as I said before. Different types of pressure act on the lungs to make you inhale and exhale. So one of the first pressures then that we've mentioned here in this slide is the intrapleural pressure. It is a pressure that is acting on the lungs and acting on the chest wall due to the fact that there is a fluid lining in between the parietal pleural and the visceral pleural. When we focus on the idea of ventilation, bringing bulk air into the lungs, we have, and this is also an important slide for test questions, we have a formula that describes how pressure and how resistance is two physics concepts, by the way, how they are related to airflow. So airflow is represented by F in this formula. Change of P, or delta P, represents the change of pressure, or the difference in pressure between the outside of the lung and the inside of the lung. So you have an intrapulmonary pressure and you have atmospheric pressure. When those two are different, they are represented by the change in pressure. This is divided by resistance, and resistance has to do with anatomy. So resistance can be anything from inflamed alveoli to a blockage in the trachea. Piece of steak from your dinner, for example, is going to provide resistance to that airflow in and out. So anything that is slowing down the process of air moving into your lungs and moving back out of your lungs is resistance. So there is a direct relationship between airflow and the change of pressure, or the difference in pressure from the outside to the inside of the body. So what that means is that the higher the pressure difference, so the higher the difference is between this number and this number in pressure, the higher the airflow is going to be. The lower the difference is between these, the lower the airflow is going to be. That's a direct relationship. On the other hand, and this should make sense to you, the larger the resistance, the lower the airflow. So when you have more resistance, you have less airflow into and out of the lungs. So that's an indirect relationship in algebra. Okay, so keep that in mind. So when you are ventilating, as I said before, your brain stem is responsible for that process. The active process of bringing air in has to do with, it's an active process, but it's active because of that pressure difference between the outside and the inside of your body. Your brain is not actively saying, take air in right now. But because of the pressure difference, the physics concept of pressure difference from the outside environment and the inside environment, air actively moves into the lungs. Exhalation, on the other hand, is a passive process simply because the recoil of the lungs is what's going to cause them to contract and push that air back out. If we dive into the alveoli themselves, we also are talking about pressure. If when the air comes in the body through the trachea and down into the deep lungs, into the alveoli sacs and individual alveoli, which is shown in this purple picture, in two different alveoli, the way that air is going to move into the alveoli is only if the pressure inside the alveoli is less than the atmospheric pressure. That is the process that is required. So there's that difference in pressure again that we were talking about from the outside world to the inside world of your body. The alveoli pressure has to be less than the atmospheric pressure for air to come in. On the flip side, for air to go out, the inside pressure has to be greater than the outside pressure. So just like we were talking about before, the bulk flow of air, where air is coming through the trachea and hasn't even gotten to the deep lungs yet, the upper respiratory system, that happens for the same reason, because the pressure within the trachea is lower than the pressure outside of the trachea. Because the pressure is higher in the trachea than it is outside the trachea, air is going to move out. So there's always that difference that we're talking about. If we start to discuss volume, which is the reason that pressure changes, we have to look at a gas law that you probably talked about in chemistry class or would talk about in chemistry class called Boyle's law. Boyle's law says that the pressure in one container and volume in one container is directly related to the pressure and volume in another container. So the containers we're talking about here are the container of the atmosphere and the container of our lungs. So for the pressure to change from one container to another container, we have said the pressure has to be higher outside, 760 millimeters of mercury, and lower inside, 757 millimeters of mercury. As a result, air moves into the lungs and the volume increases. When the volume increases, the diaphragm, which is a muscle that is part of the thorax and lies directly below the lungs, that has to contract downward to move all of the abdominal organs out of the way. So it's going to compensate and allow the chest cavity to increase in volume so that it can accommodate the increase in volume of the lungs. On the other hand, once you bring air into the second container, you're increasing. Now this number is higher than this number. Your first container now has a lower pressure than inside the second container, and the air will move out. As a result of the air moving out, what happens to the volume? It goes down. As a result, the diaphragm can relax, no longer be contracted, allow those abdominal organs to move back up into their normal space, and you expire the air. So it kind of looks like when you look at this that this is a direct relationship. But keep in mind, in algebra, if we're solving for one of these variables, how do we get P1 by itself? If you think about that, what do we have to do to this formula to get P1 by itself? Well, we have to divide this side by P1 so that we can cancel those out. I'm sorry, we have to divide this side by V1 so we can cancel those out and have P1 by itself. And what we do to one side of the equation, we do to the other. So now we have to divide this side by V1 as well. So now we realize that in all actuality, the P1 and V1 are inversely related, because now if you increase the P1, you're going to decrease the V1. We could do the same thing for the other container. So if this is the atmospheric container and this is the lung container, and we want to get V2 by itself, for example, to solve for how much volume this container has, we can divide both sides by P2. It's going to cancel them out on this side. It's going to put P2 underneath P1 times V1 on this side. And now we have an inverse relationship. And what we've said is that as the volume decreases, the pressure increases. As the volume increases, the pressure, as the volume decreases, the pressure increases. So again, it becomes, and that kind of shows you how it's an inverse relationship. I wanted to point that out because in class we were talking about this, that this looked like a direct relationship. If you raise this, you're going to raise this. Collectively, that is true, but individually, they are inversely related as shown here. You decrease the pressure, you increase the volume. And that goes for whether it's the outside container or the inside container. So far, we have talked about atmospheric pressure and transpulmonary pressure, the inside pressure of the lungs, having an effect on inhalation and exhalation. Now we're going to talk about the chest wall being another pressure that is important in breathing. So transpulmonary pressure then is, so we have atmospheric pressure out here. If this is the lung, and this is the space outside of the lung, and this is the ribs with its associated muscles. Okay, so ribs, associated muscles is known as the chest wall. Intrapleural space is the brief space between the chest wall and that pleural cavity that surrounds the lung. Okay, now we've thrown something else in there. So there is going to be a pressure difference here that's known as the transpulmonary pressure that forces atmospheric pressure to respond. Because if there is a difference between these two, air is going to either come in or come out. But in addition to that, we have the pressure of the ribs and the associated intercostal muscles that will also be placing pressure on the system. So there's always going to be a push-pull here and a push-pull here every time you take a breath in and a breath out. If you change the intrapleural pressure, so the pressure that is placed on the lungs right inside this chest wall, if you change that, so if you change the pressure right here, for example, by stabbing a lung, and placing a puncture in the lung itself. So passing through the chest wall, passing through the interpleural space, and into the alveolar pressure that is present inside the lung will collapse. So let's think about that. All of the air that would normally just come through the trachea and go into the bronchi and the alveolar space. Now you have that air, plus you have atmospheric air that's coming in through the puncture. And it fills up that intrapleural space, and the amount of pressure that's pushing on the lung now causes the air to collapse. And that's called a pneumothorax. Okay, this is labeled as number 3 because in the process of respiration, we have muscles that are involved. I've already mentioned the diaphragm. So the diaphragm is located here underneath the lungs. It can contract when it pulls down, it's contracting. When it releases, it is expanding or relaxing. You also have a little bit of pressure or contraction from the pectoralis muscles when you breathe as well, and a little bit with the sternocleidomastoid and the scalenes when they elevate the sternum to move the sternum out of the way when you're breathing so that your lungs can expand. These muscles are much less involved than the external intercostals and the diaphragm. So during inspiration then, the diaphragm is going to contract. That means it's going to move down as the arrow shows. The external intercostal muscles are going to pull the ribs up and out to allow for that additional volume of the lungs. The pectoralis minor is going to elevate or move up those just a little bit, those ribs, and then the sternocleidomastoid and scalenes are going to elevate the sternum, which is protecting your heart in the front. So that's all got to happen to accommodate the additional volume of the lungs when inspiration is occurring. The exact opposite is going to be the case during expiration. So during expiration, the diaphragm relaxes or curves up and helps to push air out of the body. The elasticity of the lungs recoil to also help push air out. The internal intercostal muscles are going to pull the ribs down and inward to also help with moving that air out of the body. Something else that affects how well your lungs function is lung compliance. And lung compliance has a normal base level for all human beings. It's defined as the magnitude of the change in lung volume produced by a given change in transmural pressure. So the greater the lung compliance, the easier it is to expand the lungs. And we are born with a certain compliance, and that compliance grows as we grow. And then the majority of humans are going to have a normal baseline compliance. Genetics plays a factor in the stretchability of the lung tissues. The environment assaults you on a daily basis with all of the toxins and can also have an effect on the stretchability of the lung tissue. The surface tension of the surfactant that I was talking about inside the alveoli that helps to keep those alveoli open. How much surfactant you have, there's a baseline normal, and if you have too much or too little, that can also affect your lung compliance. So there are these two things that can be affected by the environment and genetics can lessen the lung compliance and make it more difficult to expand the lungs. So you can start to see how complex everything is. We've got to manage pressures, we've got to manage muscles, we've got to manage alveolar surface tension, we've got to manage resistance. All of those things have to be in the positive for homeostasis in respiration to occur. So it's a pretty complex and specialized medical purview. So let's focus on that surfactant idea since it is something that is important in compliance. We talked about the fact that type 2 alveolar cells give off surfactant. When the surfactant is applied to the inside of an alveoli, it will stay open. An alveoli that does not have surfactant in it will tend to collapse. And how's that going to affect, you can imagine, gas exchange with the venules and the arterioles that are associated with these alveolar sacs? It's going to decrease. And it has to decrease because you can't have as much volume of air processed in each of these alveoli if they are collapsed. So in the beginning of your life, the very beginning of your life, the doctors, once you have passed through the birth canal, want to hear you scream. And one of the reasons that they want to hear you scream is because your lungs have not functioned on their own in vitro. And so once they come outside of the womb and they are exposed to atmospheric pressure, they need to be able to open those alveolar sacs, which are previously in this state, because they never had to work. Taking a deep breath increases the secretion of surfactant from type 2 cells. When you increase the surfactant, you increase the size of the alveoli, you increase the ability to have gas exchange going on in each of these alveoli. So for a baby, it is that process of screaming when coming out of the lungs that causes that secretion of surfactant, which starts to make their alveolar sacs functional in the outside world. So for babies that are premature, for babies that are C-section babies, a lot of times you have respiratory distress syndrome because the surfactant synthesizing cells are either too immature to put off surfactant, or they have not been stimulated to produce the surfactant. That can lead to alveolar collapse without intervention, which can lead to pulmonary edema, hypoxemia, which is oxygen deprivation at the tissue level. And you can imagine that a newborn needs gas exchange at the tissue level probably more so than any other time in your life because of the growth curve in the first 6 months of life. So that causes real problems. So respiratory distress syndrome is directly related to surfactant production inside of the alveoli. Let's go back to that airway resistance that we were talking about. The formula that we looked at said airflow is directly related to pressure difference. We've talked about that inside and outside of the lungs, and it is indirectly related to resistance. I talked about physical resistance in the form of a piece of steak that's stuck in your airway. I talked about the alveoli being having mucus or excessive pus due to some sort of infection. But there are also a couple of other ways that this can happen, and that is if you have nervous system abnormalities for the nerves that control respiration. So we talked about the fact that it's controlled by the brainstem. There are motor nerves that are attached to the brainstem that reach out to various areas within the lungs. And if there is a genetic abnormality or an abnormality in the nerves due to accidents or some other thing that destroyed those nerves, you're going to have, that's going to serve as resistance to airflow. Chemical factors that affect how, so there's some hormones and chemical factors that are secreted that will affect how wide your bronchioles are that are attached to the alveoli. If those are caused to constrict abnormally, as they are with asthma, or to not function properly in any way, too wide or too constricted, that's going to affect the airflow. So you increase the resistance in that case, you're going to decrease the airflow. All things that we need to be cognizant of as we think about all of the disorders that you're going to be dealing with as a practitioner. So one of the first disorders that you may have experience with for many different reasons is asthma, a disorder of the respiratory system. So asthma is defined as episodes where the smooth muscle contracts strongly, increasing airway resistance. It can be caused by chronic inflammation in the airways due to many different sources. So cold, dry air, tobacco smoke, pollutants in the air, viral infections, other types of allergens besides pollutants. And those bronchoconstrictor chemicals that we were talking about that can be expressed abnormally so that your bronchioles are constricted more often than they should. And we think that there may be a genetic relationship to why those chemicals are being secreted in an improper way. COPD, or chronic obstructive pulmonary disease, I'm going to skip this one. This is how it can be treated, but I want to give a definition of what it is. It includes a couple of different disorders. We used to discuss emphysema separately from chronic bronchitis. So chronic bronchitis is inflammation or accumulation of mucus in the airways that prevents the alveoli deep within the lungs of properly engaging in gas exchange. Emphysema is an actual destruction of the alveoli, and that can be caused by coal dust, for example. Miners experience what's called black lung, and that's where coal dust gets inhaled over years into the alveoli, and it actually destroys the alveoli, stiffens them and hardens them and fills them up so that they can no longer do gas exchange. Some people suffer from both of these conditions. And so that's when we started discussing this disease as COPD. It can be emphysema by itself, chronic bronchitis by itself, or both of the disorders together. And you can imagine how difficult it is for someone that is suffering from both of these and has destruction in major areas of their alveoli sacs to actually ventilate and bring in the air in the first place. And then once they're bringing in the air, the reduction of oxygenation in the blood is in direct relationship to that. This picture should be familiar to everyone. It is the lung capacity and volume picture from the lab that we did. I just want to remind you of what this part represents. That's a normal breath. That is a maximum intake of air. And this is a maximum exhale of air. Remember that this plus this plus this plus any residual air that is left in the lungs to make sure that they do not deflate is called your total lung capacity. And you may think, why do we have these extra capacities? This extra capacity and this extra capacity are helpful in the fight or flight mode. So we don't always have to use them, but we have them if it's necessary for us to engage in a higher gas exchange process than normal because we are in a fight or flight or stressful situation. And again, that functional residual capacity is that capacity that keeps our lungs inflated at all times. So this is just kind of a summary if you want to go back to that and remember. Tidal volume is normal breath. IRV is that reserve that you have for expanding your lungs in a stressful situation. This is for deflating your lungs in a stressful situation. And this is for maintaining your lungs so that they do not collapse. So, I mentioned before that there are dead spaces, and I hate that they call them that, but there are dead spaces inside of the structures of your lungs. Those are spaces where the air that comes in has nothing to do with gas exchange in the blood. So when you bring air into an alveoli, you're going to bring in some air that is not useful in the gas exchange process. So typically, a velar dead space is air that enters into the alveolar sac, and it's normally very minimal, but it can be pushed into the alveolar sac, and it remains in there and causes additional pressure within inside the alveoli. The anatomical dead space is air that remains in the conduction pathway. And if you remember what the conduction pathway, that was the trachea and the upper right and left bronchioles. Okay, so that area of we're going to bring in the air, we're going to get it down to the deep parts of the lung, that also has residual air left in it. Anywhere, it's usually close to 150 milliliters out of your normal tidal volume of about 500 milliliters that hangs out in the airspace. If you were to add both of these together, they're called PDS, and that's known as wasted ventilation. So that's air that's coming in that does not serve a functional purpose to allow oxygen and CO2 to be exchanged at the alveolar level. This slide is an important slide because you will be conducting using this formula on the test with a problem that is given to you. And so when we talk about the bulk flow of air into the alveoli, it can be affected then by the normal tidal volume that you have as a human being when you are normally breathing. It can be affected by how much anatomical dead space you have within the conduction pathway. And we're going to add something else to this. It can be affected by your normal respiration rate. And the normal respiration rate is anywhere from 12 to 20 breaths per minute. So as we look at these three individuals, we can tell a little bit of something about them just by looking at their breathing per minute. So the normal breath of patient B falls at about 12 breaths per minute. Somebody that is breathing shallowly at 6 breaths per minute is not normally breathing. Somebody breathing at 40 breaths per minute is hyperventilating. So that's where this comes from. Subject A is hyperventilating, subject B is normally breathing, and subject C is below normal breathing or relaxed breathing. Both of these situations have to be compensated for. It's going to involve brain control, that brainstem control. It's going to involve pressures. It's going to involve chemicals being released to either dilate your bronchioles or open your bronchioles up, but notice how the frequency of breath changes the tidal volume of your breath. So normal tidal volume is 500 milliliters per breath. For somebody that is hyperventilating, they're actually getting much, much, much less breath coming in during that time. So you would think if they're breathing many, 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 many more times, that that would be beneficial to the body. Not so, because as we do the calculation, we see that the ventilation goes down to 0 milliliters per minute. So somebody that is hyperventilating, it seems as if an increased frequency would be helpful to them. But when you get up to these levels, you're reducing the amount of air that you're bringing in, and you're breathing so quickly and exhaling so quickly that gas exchange is unable to occur. Normal breathing, you have a very high alveolar ventilation. When you are shallow breathing, you do have the ability then, so alveolar ventilation is raised above normal ventilation, but there are issues with this as well over time. So using this formula, I want you to know what each of these mean. So this is alveolar ventilation. This is what you're trying to figure out. To figure that out, you need to take the tidal volume, subtract the dead space, the anatomical dead space or dead volume, subtract those two first. That's what we do in order of operations. We do what's in the parentheses first. So we're going to subtract those two, and then we're going to multiply that by the frequency of the breathing, frequency of breath. Okay? So if the anatomical dead space, which we said was 150, if we plug that in here, and the tidal volume is 150, 150, there's your tidal volume, 150 minus 150 is 0. 0 times 40 is 0. That's where we come up with this number. Okay? If this is 500 and this is 150, and you subtract those two numbers and multiply it by 12, you're going to get 4,200 as the alveolar ventilation. Same with this one. Okay, now we're going to layer on another pressure. So far we have talked about atmospheric pressure, intrapleural pressure, chest wall pressure, alveolar pressure. Okay? Think about the bulk flow of air that comes into your individual alveoli through the conducting zone. It has every kind of gas that is in the atmosphere. And yet, the only two gases that are exchanged into the cardiovascular system are O2 and CO2. So here we have to be concerned at the alveolar level with what is called the partial pressure of oxygen and the partial pressure of carbon dioxide. Okay? So if the pressure of the atmosphere is 760 millimeters of mercury, of that 760, oxygen is only providing 160 millimeters of mercury pressure within that air. If the outside air is 760 millimeters of mercury in pressure, of that total pressure, only 0.3 millimeters of mercury is due to carbon dioxide. So what we're really looking at inside the alveoli when oxygen moves into the blood and CO2 moves out of the blood is those partial pressures. Okay, so remember we said that in regular old air that's coming into the alveoli, The partial pressure of oxygen is 160. By the time it arrives to the alveoli, it has been reduced to 105 millimeters of mercury. It moves into the bloodstream because the partial pressure of oxygen in the bloodstream is 40 millimeters of mercury. We always diffuse from a high to a low pressure. Okay? On the other hand, CO2 comes out of the blood and moves into the alveoli because it's moving towards the 0.3 millimeters of carbon dioxide pressure that is outside of the body. Again, high to low pressure. Okay, so it's not magic that oxygen moves into the blood and CO2 moves out. It all has to do with these partial pressures. Okay, and notice how the partial pressures change when we get down to the tissues that have a partial pressure of oxygen of 40 and a partial pressure of carbon dioxide at 46. So now we're talking about the O2 is going to move into the cells because it's at 100 and it goes towards the 40, a lower pressure. That's why it moves in. The carbon dioxide, on the other hand, is at a pressure in the tissues of 46, so it's going to move out into the capillaries to a lower pressure of 40, and that process continues. So the bulk movement of air pressure is different than, and that's an important distinction for test questions, is different than the partial pressure of each of the two gases that are exchanged. So what is it that the partial pressures do in terms of influencing the movement of blood in the body? When there is a decreased airflow to any particular region of the lung, so let's say you have the black lung from being a miner and you've destroyed many of your alveoli, and as a result you have emphysema, one of the two things that shows up in COPD. On a daily basis, your pulmonary blood is going to have a decreased amount of oxygen. What that is going to do to the blood vessels, the pulmonary blood vessels, it is going to constrict them. That's going to decrease the blood flow to the bad parts of your lung and divert the blood flow away to healthy tissue. Okay, so vasoconstriction in this, you might think, well, isn't vasoconstriction bad? Well, it would be bad if you were trying to get increased oxygen to healthy tissue, but we're talking about compensating for dead tissue. In addition, you're going to have an alveoli response or a bronchoconstriction response. So not of the blood vessels, but the bronchioles, in response to CO2 levels going down, are going to bronchoconstrict. They're also going to decrease the local, that's also going to decrease the local ventilation and divert it to healthy tissue in the lung. So your body will compensate for increased resistance within the lungs, but there eventually comes a time when enough of the tissue is destroyed that these two compensation methods are not going to help in and of themselves, and you're going to have some sort of external treatment to help with your diagnosis. Okay, so how does oxygen travel in the blood? So we've talked about the fact that it travels in the blood and it comes out of the alveoli, diffuses into the blood. Some of that oxygen, there's going to be two ways that it travels in the bloodstream. Some of it is going to be dissolved directly in the liquid portion of the plasma, and it will just travel down to those tissues, back to the heart, and it stays, unless it is needed, it's going to stay in the blood. Most of it, so 98% of the oxygen, is going to attach itself to hemoglobin on the surface of a red blood cell, and that is how it will travel over to the tissues. It will dissolve from the hemoglobin inside the red blood cells when it gets to a tissue that needs oxygen, and then it will move from a high to a low concentration. Within the cells, those mitochondria are going to use internal respiration to turn the oxygen and the glucose from your food into ATP. And then that ATP is going to be released into the cells so the cells can do their jobs. That RBC goes back to the heart, dumps off some CO2 that it has, doesn't carry very much, but some CO2. It's going to dump it off at the lungs, and then you're going to breathe it out. So how is carbon dioxide held in the blood? So if oxygen is held 2 ways in the blood, carbon dioxide is held 3 ways in the blood. The majority of it is in bicarbonate form, HCO3. It's just a chemical structure. It's a chemical ion. 25% of it is attached to hemoglobin, and then 10% of it is dissolved either directly in the blood or in the RBCs. Okay, an important test question discusses this bicarbonate. And the reason the test question is focusing on bicarbonate is because bicarbonate is involved with renal function. And so your renal function and your ability to remove wastes from your blood is intimately connected with how much bicarbonate is in your blood. So for a cell to make bicarbonate, carbon dioxide and water are broken down by carbonic anhydrase. Anytime you have an ASE ending, it's an enzyme. So this enzyme is going to combine carbon dioxide and water for storage inside the RBC. When those two things dissociate, so you get the carbon dioxide and the water from the cell, who has made those two things as a result of internal respiration. Inside the RBC, when those things dissociate or break apart, they make hydrogen ions and bicarbonate ions. Hydrogen ions are going to determine the pH of the blood, because as you increase hydrogen ions made by this dissociation, you are going to increase the acidity of the blood. That's okay if it is slightly increased. However, if you have too much dissociation of this and release of bicarbonate and hydrogen into the blood, and it changes the acidity of the blood too much, then you're out of homeostasis, and all the other things that are in the blood can't do their job. So this process that is occurring inside the RBCs that involves carbonic anhydrase, carbon dioxide, and water is extremely important in helping the renal system to be able to wash the blood of things that do not belong there. So it's a more complex system than just carrying carbon dioxide back to the lungs to be able to be exhaled so that it doesn't poison the blood. So we talked about the fact that hemoglobin carries some of the CO2 and most of the oxygen. What affects how well hemoglobin does that is that the pH of the blood stays close to 7.3 or 7.4. If it goes below that, the blood becomes acidic and the hemoglobin doesn't function the way it's supposed to. If, secondly, increased carbon dioxide, partial pressure in the blood happens, and there's many, many reasons why that would happen. If there's too much carbon dioxide then in the blood, that is a signal that hemoglobin will respond to as well, and it will not function as it's supposed to. In addition, if there is increased temperature within the body, hemoglobin cannot bind oxygen as well. If there is an increased chemical concentration of DPG, which is a chemical that is released in response to inadequate or low oxygen supply, if there is an increased amount of DPG in the blood, hemoglobin will also not function correctly. One of the test questions addresses an application of this that I wanted to make you aware of. When you are an athlete and you are training for a marathon, for example, the running posture involves both the biceps brachii of your arms, because you're pumping your arms to be able to move through air more efficiently. And it obviously also involves the gastrocnemius, which is your calf muscle. Both of those muscles then are being engaged to help move you across the surface of the earth. As a result, there is an increased temperature in each of those muscles, okay? Because they're using more energy. And the more energy you use, the more friction and the more effort you're using or giving off, the more energy that's going to be released into your body, causing the internal body temperature to slightly raise. When you're running, your gastrocnemius is having to use more effort than your biceps brachii to pump your arms. And you can imagine that. I mean, it's harder to move your entire body, which is what your gastrocnemius is responsible for, than it is to pump your arms. So the temperature in the gastrocnemius is higher than the temperature in the biceps. Therefore, hemoglobin will do a better job of dropping off oxygen to the biceps brachii, because it's closer to normal temperature, than the gastrocnemius. And when you think about going home after training for an event like that, what hurts? Your gastrocnemius. Your calves hurt. Why? Because they're not getting the oxygen that they need, because the hemoglobin is not functioning as efficiently. When your muscles are being asked to do something and they don't have enough oxygen, they convert to anaerobic respiration. That's lactic acid breakdown. And lactic acid breakdown is what causes the pain in your muscles after you've lifted weight, after you've exerted pressure using a particular muscle set. So that's just an example of what we're talking about here, of a particular situation that shows that hemoglobin needs a particular environment that's very specialized to do its job efficiently. So finally, we talk about nervous system control. Nervous system control of breathing is in the medulla oblongata of your brainstem. The medulla oblongata is below the pons in the brainstem, the two parts of the brainstem. You will notice that there are nerves that are in the medulla and there are nerves that are in the pons area. All of them are responsible for something about respiration. We'll deal with the first two in the medulla oblongata, the DRG and the VRG groups. The DRG groups fire during breathing in or inhalation or inspiration. Their job is to stimulate the muscles. Remember, we talked about the diaphragm and the intercostal muscles, to stimulate them to move the ribs so that outwards, so move the ribs outwards, so and upward and downward on the diaphragm, so that you can make space for the increased volume that's going to be of air that's going to be inside your lungs during inhalation. The VRG is a group that is responsible by being attached to some of the muscles that are responsible for your respiratory rate, that 12 to 20 breaths a minute. That is what's going to control that rhythmicity in your breathing. And then finally, the PRG group up here in the pons is responsible for making your breathing smooth so that you don't have, if you've ever heard somebody on a respirator, when there is mechanical control of breathing, the transition between inhalation and exhalation is often heard out loud when you're on a respirator. There is a noise that is associated with that. Yet when we sit and we quietly breathe, there is no noise associated with that transition between inspiring and expiring, unless, of course, you're sick. And when you're sick and you have either an upper or lower respiratory infection, that's caused because the resistance is raised. And remember, when you raise resistance, you're lowering the flow of air. When you lower the flow of air, this area, all three areas of your brain are going to be quote unquote confused, and they're going to be trying to catch up and to help you to regain that base rhythmicity that is normally in existence. An additional thing that you can do that affects these areas of your brain is bringing in legal and illegal drugs that are listed on this slide, because they suppress the inspiratory neurons that we talked about to a point in some cases where they cease working. They no longer fire. And if you do not have a stimulation to move those muscles and to expand that rib cage to allow for the additional volume that would normally be coming in from differences in pressure outside the body and inside the body, you're not going to be able to have that alveolar ventilation occurring. And eventually you're going to have a cessation of breathing altogether. Because remember, breathing starts with ventilation. And if you don't have a stimulation for ventilation, the entire cascade of the process of the lungs expanding and contracting cannot start. There's my slide for the PRG group. I must have switched them around. I don't know why. So those are brain areas. Now we're going to look at real quickly the motor neurons that extend out of the brain that can respond to changes. So if there is a change in carbon dioxide or oxygen partial pressure levels in the blood, if there's a change in blood pH, motor neurons called chemoreceptors. The receptor part of it is called a chemoreceptor that is responding to chemical change. Some of them are located in the medulla oblongata. Some of them are located on the aortic arch and the carotid arteries. Those are called peripheral chemoreceptors. The ones on the medulla oblongata are called central chemoreceptors. They have motor neurons attached to them that will directly affect the muscles of breathing. We know, as we just said in the last slide, that if you are compensating for decreases in gas exchange at the alveolar level, you need to increase the alveolar ventilation. You need to bring it back to a normal level. The levels that we talked about when we did the calculation on alveolar ventilation. You need to bring the breathing rate back into line to normalize it between that 12 to 20. You need to bring the tidal volume back into line around 500. And then you need to maintain that dead space that we talked about in the conduction area. You need to maintain that blood. So all of the areas in the respiratory system have to be modulated or changed. Could be by constriction of cells, it could be by diversion of materials, whether it be respiratory materials or blood materials. But in any case, these chemoreceptors are attached to the muscles of breathing, which will then bring the alveolar ventilation back in line. Other chemicals are going to be released by the renal system that will bring the partial pressure of CO2 and the partial pressure of oxygen and the blood pH back in line. So it's a complex situation. Okay, I want to focus real quick here. What I want you to get from this slide, I included a picture that has a discussion of both respiratory acidosis and alkalosis and metabolic acidosis and alkalosis. The only thing that's explained on this slide is the metabolic acidosis and alkalosis. And I want to compare and contrast them because I think that's important. So, your blood pH can go up and down as a result of metabolic or chemical activities in your bloodstream, in your tissues. That is called metabolic change. So when you think about the digestive system, your metabolism, when we say, well, I have a low metabolism, that's why I gain weight easily, or I have a high metabolism, I can eat anything and I don't ever gain weight. What you're really saying is your body is either not efficient at burning off nutrients or breaking down nutrients from your food, or it is efficient at doing that and releasing those nutrients into your bloodstream so they can be used by your cells. So, metabolic alkalosis and acidosis then has to do with a chemical change in your blood that is not due to how much air you're bringing in and out of your body. Okay? So it's not due to gas exchange. It is instead due to some chemical process in your body that is changing the pH of your blood and causing responses that may be helped by differences in your respiratory rate. So the cause is not respiratory, but the respiratory can help to compensate for it. So an example of metabolic acidosis is that lactic acid production that I was talking about during strenuous exercise. When you produce too much lactic acid during anaerobic respiration, that lactic acid ends up in your blood, causes an increase in hydrogen ions, and a decrease in your blood pressure, or in your blood pH. That means your pH becomes acidic. As a response, reflex hyperventilation will help you to speed up that ventilation and get rid of excessive CO2 in your body. So let's go back to that bicarbonate and hydrogen dissociation that happens in your red blood cells. So once the lactic acid gets into your bloodstream, your red blood cells are going to respond by creating carbon dioxide and water out of bicarbonate and hydrogen, increased hydrogen levels in your blood. Remember how that was done? That enzyme takes the carbon dioxide and the water and can break it down into bicarbonate and hydrogen, but it can also rebuild it. So that then you get rid of the excess bicarbonate, you get rid of the excess hydrogen, and you can therefore get rid of the carbon dioxide and bring your pH back to a normal level. The opposite of that is the pH of your blood decreases or increases because you don't have enough hydrogen ions in your blood. That can be due to excessive vomiting, maybe excessive vomiting associated with bulimia, for an example. That's going to cause reflex hypoventilation. So slowing down the ventilation to increase the level of carbon dioxide in your blood in the form of bicarbonate, to increase those levels so that your blood pH goes back up to around 7.4. Okay, so having dealt with these then, there are also the direct effect of respiratory blockages. Respiratory blockages are going to also mess with the pH of your blood because it's messing with the level of carbon dioxide in your blood. If you are unable to get rid of carbon dioxide due to a blockage in your alveoli or in the conducting system of your respiratory system, it's going to change your pH. It's going to cause you to have respiratory acidosis. If, on the other hand, the CO2 level is going down, that means that you need more CO2 in your blood. So you're going to start creating more CO2 in your blood by hypoventilation, slowing down your breathing so that you can bring that pH up again. But these changes are caused by a restriction of the airflow. These are caused by chemical reactions that are dumping into your blood. So that's the difference between the two of them. An example of a hypoventilation disorder that can change those arterial flows and change the pH of the blood is obstructive sleep apnea, and it's very common. It can be caused, the green areas up here, it can be caused by decreased upper airway dilator muscle activity. So you have a muscle disorder. Muscular dystrophy, for example, may eventually cause this issue, where the muscles are not properly opening the bronchial airways to allow air to come in. Obesity, when you're laying on your back and there is excess weight on your neck and your chest, that's going to change partial pressures, and it's going to block the airflow so that you have a reduced airflow going into your body. Compromised upper airway anatomy could be from a blockage, could be from mucus, could be from something that's stuck in your throat, but all of those could be causing a closure of airway during sleep, because during sleep we slow our breathing down anyway. To 12 or slightly around 12, maybe even slightly below that. And so as a result, we're not breathing out as much CO2. So the arterial level of CO2 drastically increases, and the arterial level of O2 drastically increases because we're not bringing in any new O2. As a result, you're going to have frequent arousal, you're going to have sleep deprivation, sleep disruption by snoring. The next day, you're going to feel fatigue. All of those things then play into long-term medical problems. It can also affect your heart, because you have to keep in mind your heart muscle needs oxygen for those muscles to function as well. And if you're depriving your heart muscle of that oxygen, your heartbeat can be affected, your heart efficiency in pumping blood around your body can be affected. That can lead to stroke, that can lead to arrhythmias, that could lead to blood clots. The way we treat obstructive disorder, obstructive disorder, is with CPAP therapy. And you'll see a lot of patients that you have in the ER, in long-term care, in hospitals. They actually have to have CPAP therapy when sleeping, because the healing process also requires the correct amount of oxygen and CO2 and the correct amount of rest and a lack of stress. And so simply having a set pressure that brings oxygen in at a set pressure and pushes whatever the resistance is out of the way, so that your lungs get the oxygen that they need and release the CO2, will lower that arterial level of CO2 and increase that arterial level of oxygen, so that you do not suffer the symptoms long term.